Alright, so now I'm going to talk about hyponatremia versus hypernatremia. So I'm just going to go through sodium, potassium, and calcium and see what high levels and low levels of this have an effect on the patient. So hyponatremia is characterized by excessive sodium losses. So hyponatremia is anything less than 135 millimoles per liter. It's not only due to excessive sodium loss, but also could be due to inadequate sodium intake. There's excessive water gain that could cause hyponatremia, and so these can be caused by excessive hypotonic IV fluids, so 0.5% normal saline. Since there's more water than electrolytes, the water is going to move from the extracellular fluid to the intercellular fluid, and the cells will swell. Disease states that cause hyponatremia include SIADH, heart failure, primary aldosteronism, cirrhosis, and some psychiatric states. And so psychiatric states, anorexic patients have a low sodium level, and also people who are polydipsic, if they intake a lot of water, they can basically drown their own body. So if a patient is hyponatremic, you're going to give them a hypertonic solution, which is 3% normal saline. Hypernatremia is anything over 145 millimoles per liter. So this is due to excessive sodium intake, inadequate water intake, excessive sodium loss, or disease states including diabetes insipidus, Cushing's syndrome, uncontrolled diabetes, and hyperaldosteronism. So clinical manifestations of hyponatremia include cellular swelling and CNS changes. So a person can become confused, and eventually this could lead to a seizure, coma, or 30 pulse. So if a patient has a sodium that's under 120, they're going to be in the ICU. With hypernatremia, water is going to shift out of the cells, and it's going to the cells are going to shrink and become dehydrated. So this is rare. Your patient's just going to be wicked dehydrated. So nursing implementation. For hyponatremia, you're going to replace the fluid loss with isotonic solutions, so 0.9% normal saline. You're going to encourage oral intake, and you're not diuresing your patient because you want them to intake fluids. Your patient will be on a fluid restriction, and it's just going to be 500 milliliters less than the previous 24-hour output. If your patient is seriously or acutely hyponatremic, you're going to give them 3% normal saline. Drugs that help with hyponatremia include vasopressin, which blocks ADH. This is going to increase urine output, but doesn't allow for sodium loss. For hyponatremia, you're going to correct the underlying cause and try getting your patient back to homeostasis. IV fluids you're going to give isotonic, always start out with that. And then you might have to give them D5W and also loop diuretics such as furosemide. That will help with hyponatremia. Your patient's going to be on restricted sodium. So since normal is 2,400 milligrams per day, we want your patient on a low sodium diet just because they're already hypernatremic. You don't want them taking in more sodium. Nursing care for hyponatremia, strict INOs, you're going to monitor labs and replete slowly. So basically, you shouldn't increase your sodium by too much. So if you overcorrect sodium, you can cause cerebral edema, which causes increasing intracranial pressure. With increased intracranial pressure, you're going to see a Y in pulse pressure. So this could be like a pulse pressure of 150/30. Patients who are hyponatremic are on seizure precautions. There has to be suction working in the room. They might have a urinary catheter, but you might want to prevent this because of the risk for infection, and they'll have daily weights. You want to talk to your patient about reducing their fluid intake and want them to consume more sodium, basically, but not drink as much. Alright, so hypo versus hyperkalemia. So hypokalemia is when there's less than 3.5 millimoles per liter. This is due to GI loss, kidney dysfunction, magnesium deficiency, insulin therapy, or metabolic alkalosis. For hyperkalemia, the most common cause is renal failure. There's massive cell destruction, adrenal insufficiency, and also potassium-sparing diuretics such as spironolactone can cause hyperkalemia, which is any potassium level over 5. For hypokalemia, you're going to get cardiac issues, so there's going to be impaired repolarization and flattening of the T wave. There will be a presence of a U wave, and you might see peak-to-peak P waves. People can become DIG toxic because DIG has such a narrow therapeutic range, and the potassium level that's low is going to predispose them to digoxin toxicity. Patients might have skeletal weakness or paralysis and respiratory muscle weakness. They could go into heart block, left ventricular, and they could have lethal ventricular arrhythmias, so VTAC, VFib. Hyperkalemia leads to increased cellular excitability, so this could cause a lethal arrhythmia as well, and it causes cramping, leg pain, and weakness. In a patient with hyperkalemia, you're going to see a flat P wave, a wide QRS, and a narrow T wave that's more peaked. So nursing implementation for hypokalemia, you're going to give your patient potassium chloride supplements. You always want to dilute it since it's caustic to peripheral veins and it tastes bad, PO. So peripheral IV potassium, you can't infuse it faster than 10 to 20 ml equivalents per hour because you're worrying about infiltration. You never bolus potassium because the patient will die. You have to assess the IV site frequently and increase dietary intake of potassium, so have your patient eat bananas, potatoes, and orange juice. For hyperkalemia, you want to eliminate all their potassium intake, so you want to also increase the elimination. If your patient has a K of 6.9, you're going to administer IV insulin with G50. You can also give your patient K-Exalate, which is osmotic medication that pulls potassium out via bowel movements. If your patient's on K-Exalate, make sure they have a bedside commode. Dialysis can also be used to correct hyperkalemia, so basically you're going to force potassium from the extracellular fluid into the intracellular fluid, so it gets out in the blood and can be cleaned out. And you're going to administer calcium gluconate. Hypo versus hypercalcemia. So hypocalcemia is when it's caused by a decrease in PTH. So in hypoparathyroidism, also acute pancreatitis, multiple transfusions, and a low calcium intake. Hypercalcemia is caused by hyperparathyroidism, malignancy, prolonged immobilization since the bones weaken, and the calcium is going to come out of the bones and go into the blood. Also, hypercalcemia can be caused by a vitamin D overdose. Clinical manifestations of hypocalcemia include tetany. You might see Trousseau's sign, in which the hand flex, and Chauvet's sign, in which you tap your patient's cheeks and they kind of grimace. If a patient has their thyroid removed, you want to check for signs of hypocalcemia. So check Chauvet's and Trousseau's signs and get their labs. With hypercalcemia, your patient's going to be lethargic and weak, anorexic, nausea, vomiting, have bone pain. They'll have nephrolithiasis because the kidneys cannot eliminate calcium, and this leads to stones. Patient can be confused, psychotic, have personality changes, and impaired memory. For hypocalcemia, you're going to treat the cause, give oral and IV supplements, and increase dietary intake. So foods that are high in calcium include milk, yogurt, ice cream, and cheese. For hypercalcemia, you're going to administer loop diuretics. Never give a patient calcium gluconate. You're going to hydrate them with normal saline. Oral intake should be 3 to 4 liters of fluid, basically to flush the kidneys out and get rid of all that excess calcium. And if it's with malignancy, you're going to treat that. All right, awesome. Thank you.